Hello, this is Dr. M. Nurul Akhtar Hassan, Pediatric Intensivist and Associate Professor, Pediatric Intensive Care Unit, National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh. Today we shall discuss patient-ventilator asynchrony. We shall mostly focus on flow, cycle and other asynchrony, because in a previous lecture we discussed trigger asynchrony in mechanical ventilator. Today's learning objectives are patient ventilator asynchrony, types of asynchrony, asynchrony of flow and cycle, other types of asynchrony, and finally a brief summary. These are the four basic parameters determining mechanical breaths. We have a separate lecture on it, but to understand today's topic, I shall briefly discuss about this. First is triggering, which is the initiation of a breath, how the breath will be initiated by mechanical ventilator, whether it will be initiated after a certain period of time as said by respiratory rate or by patient itself. Patient trigger further can be flow trigger, pressure trigger or electrical activity of diaphragm. Second is flow. When a breath is triggered, ventilator will deliver a breath inside the lung, and how the flow will be entering into the lung to expand it, whether it will be constant flow or decelerating flow. Third is the limit. This is the mechanism of limiting the breath. In other term, it is the size of the breath. How much the lung will be expanded to a certain volume limit or to a certain pressure. And finally, cycle. It is the termination of breath. How the breath will be terminated, how the inspiration will be terminated. Will it be terminated after a certain period of time as we set the inspiratory time, or it will be terminated after delivering a certain percentage of flow. So, patient ventilator asynchrony is discrepancy between patient demand and what ventilator delivers. If there is no synchrony, then patient will have patient ventilator asynchrony. This is a common phenomena, most common being ineffective triggering. It might be due to patient, ventilator or both. Most common types of patient ventilator asynchrony are triggering asynchrony, cycling asynchrony and flow asynchrony. This is the flow waveform and pressure waveform in volume limit ventilation. So, this is the volume limit ventilation flow waveform and this is pressure waveform. In volume limit ventilation, we give a fixed amount of tidal volume to expand the lung with a fixed flow. So, here flow and tidal volume is fixed. Maximum flow is delivered at the beginning of inspiration and then a constant maintenance of this flow up to the end of inspiration. That is why the flow curve in volume limit ventilation is box like or square waveform. As there is constant flow delivered inside the lung, there is gradual increase in the pressure inside the lung and which peak at the end of inspiration. The opposite is true in pressure limit ventilation. In pressure limit ventilation, pressure is fixed inside the lung. At the beginning of inspiration, maximum pressure is reached up to the point as said by P peak or pressure control or peak inspiratory pressure, and the whole period of inspiration, that pressure is maintained uniformly, and to maintain this pressure uniformly, flow has to be reduced over time. So, it is decelerating flow. So, flow is gradually coming down from the beginning of inspiration to the end of inspiration to maintain a constant pressure inside the lung. So, in volume limit ventilation, flow is constant, tidal volume is constant. In pressure limit ventilation, pressure is constant. Now comes cycle. It is the termination of inspiration. Most commonly it terminated after a certain period of time, as we said, by inspiratory time or I time. But in pressure support mode, we do not set any respiratory rate or inspiratory time. In pressure support mode, inspiration ends when a certain amount of flow is being delivered. Usually by default in ventilator, it ends when 25 to 30% of flow is delivered in pressure support mode. The inspiration is terminated and expiration started. Usually you do not need to manipulate this initially, because ventilator by default set a 30 or 25%. For the beginner it should be okay, but over time when you become expert and understand in detail, then you can adjust accordingly. This is the pressure support ventilation curves. Yellow one is the pressure curve, inspiration and expiration. Red one is the flow curve, and below is the volume curve. So, at the beginning of inspiration, when pressure drops due to patient's effort, ventilator delivers a breath. Ventilator triggers the breath and delivers the breath, and it starts flow, delivering gas flow inside the lung, and it reached up to a certain point to reach a pressure of set pressure support. So, it will reach that point what we have set in pressure support limit. So, after reaching that point, in the beginning of inspiration, as the inspiration goes on, the flow will come down gradually. So, this is the maximum inspiratory flow at the beginning of inspiration to reach this pressure. This is here in this patient, it is 10 liter per minute. So, after this 10 liter per minute, inspiration will be ended after certain percentage of this flow delivery when it is completed. Say exhalation occurs at set percentage of peak flow, and as I told earlier, it can be 25 or 30 initially by default. So, 30% of 10 liter is actually 3 liter per minute. So, when flow gradually coming down and gradually getting reduced, when it comes to the point where flow is 3 liter per minute, then inspiration ends at its terminal point. So, here is the end of inspiration and beginning of expiration. If you see this picture, you will understand more. Just follow the bottom picture. This is the maximum flow, that is the 100% flow, and here flow cycle set at 10. That means after when flow is getting reduced or coming down, when percentage of maximum flow is delivered to 10%, say here it is gradually coming down 70%, 50%, and when 10% of this maximum flow is being delivered, the inspiration will be ended. Here it is 20%, 25%. So, So, when 25% of flow is delivered here, inspiration ended and expiration started, and here it is 25%. So, if you follow carefully, when it is 50%, inspiration ended little more earlier and inspiratory time is narrow. Here it will little more and here more. So, if you set the threshold higher, inspiratory time will be shorter. If we set threshold lower, then inspiratory time will be longer. So, these are the types of asynchrony: trigger asynchrony, cycle and flow. As we discussed trigger asynchrony earlier, today we shall discuss only premature cycling, delayed cycling, that is asynchrony is cycling, and flow cycling, flow asynchrony, that is insufficient flow or excess flow. Premature cycling, it is if the inspiratory time is too short relative to patient inspiratory time. That means, patient is taking a longer inspiration, but ventilator discontinue providing inspiration and ended earlier. So, when patient ventilator terminated inspiration and started expiration, patient is still on the inspiration, that is premature cycling. It can happen if there is low level of assist provided by the ventilator, or if there is relatively high threshold for cycling in pressure support mode. So, if case of premature cycling, the chance of double trigger is more. So, in therapeutic measure, to prevent or to avoid premature cycling, we have to in volume control ventilation, we have to decrease the inspiratory flow, which will reduce the inspiratory increase the inspiratory time, or we can increase the tidal volume or end inspiratory pause. In pressure control ventilation, we can directly increase the inspiratory time, and in the pressure support mode, we have to lower the threshold for cycling. Say if it is 50, then we can lower it to 25, or higher pressure support can be provided, or slower rise time in pressure support ventilation. That can help to avoid premature cycling. There may be some patient's factor like restrictive respiratory mechanics in pressure support ventilation or intense inspiratory muscle activity. So, in that case, decrease or lower cycling threshold can help, or increase pressure support. This is an example of premature cycling. This is the flow curve, this is the pressure curve, and this is muscle activity of inspiratory muscle activity. So, if we look carefully, this is the inspiratory effort of the patient. The inspiration ended here, but patient still in muscle is contracting. So, patient is still in inspiratory phase. So, patient inspiratory phase actually ended here. So, there is a gap between patient inspiration ending and ventilator ending. So, ventilator inspiration ended earlier, that is premature cycling. So, what we can do here, cycling is set at 50. If we set at 25, then inspiration is little wider, and if we set at 10, then it is more wider and it is almost close to patient effort. Then is delayed cycling. It is the opposite of premature cycling, where inspiratory time is too long relative to patient inspiratory time. That means, patient completed his inspiration, but ventilator still continuing the inspiratory phase. In assisted volume control mode, higher tidal volume, increased inflation time, low inspiratory flow and application of end inspiratory pause can also be culprit of this delayed cycling. And in pressure support mode, low threshold for cycling and high support or low rise time can cause delayed cycling. So, in therapeutic approach, to avoid this delayed cycling or to manage this delayed cycling, we have to increase the inspiratory flow, which will decrease the inspiratory time of patient ventilator breath. In pressure support ventilator, we can directly reduce the inspiratory time in pressure control ventilation, and in pressure support ventilation, increase the cycling threshold percentage or decrease the pressure support level, and bronchodilator and steroid therapy if there is patient's bronchospasm or secretions. There are some patient factor like obstructive respiratory mechanics in pressure support ventilation can cause this delayed cycling. In that case, increase the cycling threshold may help to prevent this delayed cycling. Also, reducing pressure support can help. This is an example of delayed cycling. This is the flow curve and this is the pressure waveform, and this is the patient's muscular activity. If you see, muscular activity is ended here, but patient inspiration still continuing when patient actually entered into a expiratory phase. So, patient in the expiratory phase, but ventilator still providing its inspiration. So, there will be an asynchrony and discomfort. So, here threshold set lower. So, if we set threshold little higher 25%, then little better than previous, and if we set 50, then it is almost close to patient effort. So, in this way we can manage this delayed cycling. This is in pressure support mode. If it is in pressure control mode, then we can directly reduce the inspiratory time. This is another example. This is the flow waveform and this is the pressure waveform in pressure support ventilation. So, this pressure waveform should be box like or square form. So, it should be like this somehow, but as there is delayed cycling, there is patient's inspiration is ended here. This is the esophageal pressure. So, patient inspiration ended here, but ventilator is still in the inspiratory phase. As a result, here patient ended inspiration and enter into the expiratory phase, but ventilator still providing inspiration. As a result, there is a rise in pressure. So, if you see this form of a coning or stipple appearance at the end of inspiratory pressure rather than square form or box like, then it is may be due to delayed cycling. Next is insufficient flow. There are some ventilator factor and some patient factor. In ventilator factor, in volume control ventilation, the flow setting is too low, or in pressure control or pressure support ventilation, applied pressure P peak, PIP or pressure support is too low, or there is long rise time. So, in volume control ventilation, increase flow or switching to pressure control or pressure support can help. In case of patient factor, excessive ventilatory demand or increased neural drive may cause this problem. In that case, reducing neural drive and metabolic demand by control of fever, pain, metabolic acidosis and anxiety can help. This is an example of insufficient flow. This is the volume curve and this is the flow waveform and this is the pressure waveform. We know in volume limit ventilation flow waveform is square form and this is volume limit ventilation triangular pressure waveform. Here if you see, this is not triangular, rather at the beginning of inspiration, rather than gradually increasing the pressure, there is sudden dip in the pressure, scooping of this pressure waveform. That is actually due to at the beginning of inspiration, when the inspiration started, patient feels air hunger and patient feels insufficient flow. That is why patient tries to take a deep breath and diaphragm contracts. As a result, there is dipping in the pressure waveform in volume limit ventilation. So, this scooping is due to insufficient flow. So, if we see this type of scooping, we can diagnose that there is insufficient flow. So, we can increase the flow or we can start pressure control ventilation. Here pressure control ventilation started, and after starting pressure control ventilation, if you see, this scooping is gradually disappearing and coming to normal. Excess flow. In volume control ventilation, the flow setting is too high, or in pressure control or pressure support ventilation, applied pressure is too high. So, we have to reduce this flow, or in volume control or in pressure control or pressure support, we have to reduce the peak pressure or pressure support setup. There are other type of asynchrony like pressure support induced apnea, inappropriate rise time and discrepancy between patient's need and ventilator support. So, in pressure support mode, if we provide excess ventilation by higher pressure support, then that cause low PCO2, which can reduce the neural drive for respiration and can cause central apnea. And this central apnea in pressure support ventilation can cause sleep disturbance and periodic breathing and patient discomfort. So, pressure support can be adjusted and use of backup ventilation can help this sleep disturbance. But in backup ventilator, there will be less use of patient muscle. So, there may be downside also. This backup ventilator patient set automatically by default when you set pressure control ventilation, pressure support ventilation. But as it is set by default, it may not be appropriate to the patient. So, it is better to set this backup ventilator setting by yourself as per your patient's demand. Then is the inappropriate rise time. It is the rise time is available in pressure limit mode like pressure control ventilation or pressure support mode. It determines how fast the ventilator will reach the selected peak airway pressure. Too fast rising time, there will be a sharp increase in inspiratory flow and there will be pressure overshoot and patient may feel dyspnea. On the other hand, if it is too slow, then rounded shaped inspiratory flow waveform may happen and that will also be insufficient and may cause flow hunger. So, both may provoke dissociation between mechanical and neural breath. Since there is no rule for setting an optimal rise time, it should be adjusted according to patient's respiratory drive. Normally, machine has a default setting, but For the beginner, it may not be easy to understand and to manipulate this thing, but over time if you understand this flow and waves, and if you can understand this asynchrony, you can set this rise time by yourself. This is the pressure waveform in pressure limit ventilation. We have shown it box like, but it is not perfectly box like or square. At the beginning of inspiration, there will be gradual rise of pressure to the point of PIP or pressure support, what we have set. So, it is not sharp rise, it is gradually it rise here. So, from beginning of inspiration to reaching the maximum pressure, this is the rise time. If it is more vertical, then the rise time is shorter than previous one. On the other hand, the slope may be more, then longer rise time can happen. So, it should be appropriate. It should not be too fast like sharp rise or not too slow, too sloping. It would be something medium and comfortable to patient. Low ventilator assist and this is high ventilator assist. If pressure support is too much, too high, then this type of flow waveform may be visible with sharp downward slope at the end of inspiration. So, ideally pressure support can be set at 10 or 12, 10 can be a beginning pressure support, or alternatively whatever peak pressure or PIP or pressure control you have set, you can set a pressure support of 2/3 of the pressure control. Say if you set pressure control of 15, then 2/3 of 15 is 10. So, you can set 10 pressure support and adjust accordingly after observing the patient's demand. If patient demand more, then you can increase to 12, 14. If patient is feeling high assistance, patient tidal volume delivery is too much, you can reduce it gradually. So, we are at the end of this lecture. In summary, this asynchrony may be largely underestimated because of frequent lack of monitoring, but physician must pay more attention to the interaction between patient and ventilator. It may occur at any phase of respiratory cycle, whether inspiration or expiration. It can be due to time discrepancy of ventilator assist or respiratory demand discrepancies. Deep sedation should be avoided, which is also one cause of asynchronies. Asynchronies negatively correlates with clinical outcome. It may cause prolonged ventilation and worse outcome. The gold standard for their recognition is the documentation of patient effort, and the most important thing is careful inspection of the ventilator screen along with the clinical picture of patient is sufficient for the physician to recognize patient ventilator desynchrony or asynchrony. New proportional modes of ventilator are also helpful in improving patient ventilator interaction, but they are not available in all models or all brand of mechanical ventilator. Finally, spend more time at the bedside to identify asynchrony early and correct the cause. You may not be able to understand today's lecture also or initially if you are beginner, but if you see the lecture repeatedly and if you follow your patient and your patient's monitor bedside regularly, then you will be understanding everything nicely. Thank you all.